I just did an analysis of our deficit. You know, deficits fondly talked about overspending and spending on the military and bureaucracy and so on and so forth. But when you boil it down, a huge portion of our deficit is healthcare expenditure or healthcare deficit. And if you run this out 20 years, even according to the figures we get from the OMB, Office of Management and Budget, or out of the Congressional Budget Office, CBO, the bulk of the deficit going forward is healthcare.
Yeah.
They call it entitlements, but actually, if you look at entitlements, even Social Security is fairly constant as a deficit, as a percentage of our total budget, but not healthcare. Healthcare seems to grow every year, and if you stretch it out, it's growing forever. And there just seems to be no solution to it. It seems that for whatever reason, the United States has not been able to solve the healthcare budget problem. And here's the kicker. The kicker is the quality of health in the United States, not quality necessarily of healthcare, but the quality of health in the United States is at an abysmal low level, probably the worst since the 30s, and it seems to be going down. It seems that our life expectancy is reducing dramatically. Now, some of that may be the drug crisis, but a very significant portion of it is obesity, which seems to be increasing all the time. So what's the answer? You're the maverick that is in the healthcare industry, in the healthcare business. How do we get out of this mess?
I think I'm glad we made the time, because this is a long conversation. Here's the good news.
Okay.
There are solutions, and they're already available, and they're already ready to go. And there's no innovation, if you will. A lot of times when we talk about disruptive innovation.
Yes.
We talk about doing new things, AI, LLMs.
Yes.
We talk about tech, SpaceX.
Right.
This problem or set of challenges that we have in the United States and globally, right? I always tell people, I'm interested in affordable and accessible healthcare for everyone, everywhere, right?
Okay.
I love the United States, not from here, neither are you, but I love people. I'm interested in solving it everywhere. And the solutions to solving it everywhere they're available today. And so I think the nice thing about this discussion is the solutions exist, they're available, but what we need is to do them. And so I think our discussion today will be largely centered around doing that. I think you have to break them down. So you have to break some things down. We have to teach. I mean, I've been doing this now 25 years. You have to teach people certain things like what's Medicare, what's Medicaid, what is a fully insured health plan, what's a self-funded health plan, what's a self-funded health plan with a captive, what's workers' compensation, because those are the things that all cover health care and risk transfer within healthcare.
Is it, let me ask you this question. Is our problem structural? In other words, are those components of healthcare just the wrong components? Or are those components okay, but we have to reform those components? At bottom, why are we on this downward slope instead of an upward slope? What is the underlying cause of this malaise?
Well, I think we talk a lot about first principles.
Yes.
And when you ask a lawmaker for a solution, or you ask an insurance company for a solution, or a health system you'll never hear first principles.
Right.
The biggest challenge we have is price discovery. And somebody will say, well, what is it like? Who cares? No. If you don't know the price, the market can't signal anything, and no one knows anything.
Right.
And we don't have any economic signals to help us. Here's an example. we don't have the three basic economic marketplaces in healthcare. We don't have brokerages, we don't have e-commerce solutions, and we don't have commodities exchanges. Now, people have tried to build all of those, including me, and they've been largely unsuccessful. I don't think they were unsuccessful because the tech was bad or the idea was bad. I think it's timing. I think all three of those things will be highly successful in the next 5 to 7 years.
Well, famously, Amazon, Jeff Bezos,
Yep.
and JP Morgan Chase, I mean, we're talking about the two largest companies in their space, and two of the largest companies in the United States, and two of the most brilliant business people try to do this together.
Yes. And Warren Buffett, don't forget. Yeah.
And Warren Buffett. Yes, I forgot about Warren Buffett. So Jamie Dimon, Warren Buffett, and Jeff Bezos. Now, if those three guys can't solve it, how's you can solve it?
Well, I think they could solve it if they wanted to. I think their interests are highly entrenched. And
do you really think that their interests are what drove them?
Or 100%.
Oh, you think so?
Yeah. I mean, I've spent years thinking about it, and it's not something I'm saying to be provocative in any way. It's a matter of fact of like, here's the logic, here's where we're going, and why would you not want to solve these problems, or why would you want to solve them?
Right.
I mean, Amazon could solve the e-commerce problem tomorrow.
Yeah.
Here's a for instance. Jeff Bezos said, I want, just to give some understanding, there are 18 billion medical treatments and services rendered each and every year in the United States, or there has been since 2018. That's not including pharmaceuticals. So the average pharmaceutical, so the Americans consume about 16 scripts per person per year. So that's a whole different number. That's a massive number at 330 million people. But 18 billion medical treatments and services. Now, to give you an idea, only about 115 million of those are ER, super acute, there's a trauma problem issues.
Yeah.
Right, so you get 17 billion, 909 million normal challenges. 15 billion of which are lab tests. 1.2 billion of which are physician consults. You make a doctor's appointment. 400 billion are physical therapy visits. Hey, I'm going to have surgery, I think, or I just got finished with surgery. I need to learn how to stretch and move my body. You have 300 million radiology appointments. CTs make up the largest of that, then MRIs, PET scans, X-rays, mammograms. Next, gastroenterology, which is colonoscopies and upper endoscopies, right? They always say, it's a joke.
I get it.
You get it? Okay, so, but the point is, Jeff Bezos could solve that problem tomorrow. I mean, if you think, so the average paid claim for a popular, like utilized 1 billion times a year, lab test is $144. But if you look on the internet and you go to some sites that sell lab tests, they sell these same lab tests in a plethora of locations around the United States for $15 at most.
Wow, that's a huge difference.
Humongous delta, right? But remember, there's no price discovery, so there's no market.
Yeah.
So there's no, what we would call, I don't want to get too crazy on math, but there's no, we don't see any mean reversion or reversion to the mean, right? You don't see the market collapsing anywhere.
Yeah.
And I think what everybody in the country really wants is for that to happen. They want price discovery. Hey, every time your insurance pays for you to have a lab test, it's $144. And every time you go to the store, look it up on the internet, it's $15. What happens when, Americans figure that out?
But I'm removed from my pricing. I have no idea. It's not even price discovery. It's just I am not empowered to look at pricing, because the whole idea of what I pay, what I have to pay for, and how much I have to pay for it is completely behind the paperwork. I just go to the doctor and I get the result of my insurance claim, and that's it.
true on some aspects, but less true over the last 10 years. So you've got 100 million people now on high deductible health plans, right? 140-ish million people are covered by employers in the United States, employer-sponsored healthcare. Now, we can get into the fact that I don't think employers actually care about their health plan. We can get into that later.
Yeah.
But as a matter of shopping or incentive, high deductible health plans were created, one, to lower premiums, which they haven't been able to do.
Right.
But they also wanted to encourage shopping, because 90% of Americans today that are covered by insurance don't meet their deductibles. Co-pays, co-insurance, those limits, the out-of-pocket max limits. And so when you look at that, you say, well, there's every incentive for Larry Goldberg to shop, but he doesn't have the right tools in order to do so.
Yeah.
Yeah, and I think the tools are missing. So back to our Bezos example, if Jeff Bezos all of a sudden said, I am going to put MRIs and CTs on my site, and I'm going to put lab tests on my site.
Right.
And by the way, this wouldn't be hard to do. There's already people doing this.
Right.
Right. It's not hard. I was one of them. If he said, let's just say everything under $6,000, right, which is 80% of that 18 billion.
Right. That's a huge amount of money. That's $14 billion.
That could be on Amazon tomorrow. It's not hard. And when I say tomorrow, I really mean tomorrow. All of that data, all of those CPT codes, all of that information already lives in the marketplace. And those companies that do that have those cash prices ready and available because they sell them to employers, all of that could be in Amazon tomorrow. And if you had that, Jeff knows this, I'm not telling anybody in Amazon that anything they don't know. That would have helped the problem tremendously.
So why don't they do it?
I don't know. Are you friends with them? Can we find out?
Well, this is shocking to me. Are you really seriously saying that, I don't know, Walmart, Amazon, I don't care. I'm not a...
By the way, I don't think Walmart's there. I don't think they've ever thought about it or tried to do it. We've had some conversations with Walmart when, who's the guy from Jet.com? He ran Diapers.com.
Oh, yeah.
He went to run Walmart e-commerce.
Yes.
We spoke with him early on, and he didn't have any interest in it. But my conclusion walking out of that meeting in Bentonville at the time wasn't that he didn't like the idea. It's that they were really trying to build up. They'd just sold. He had just come on, and they were really trying to move towards that market.
Well, yeah, let's not personalize it. Let's just say that if this were possible, this should have already been done.
Must have already been done. Yes.
Yeah,
you're correct.
So
here's what I think it is.
Yeah.
Here's what I think it is. And I wasn't trying to in any way personalize or make judgments.
Yeah.
I tend to just point at things and say, why aren't they done? If you look at healthcare as a whole, everything lags by about 17 years.
Wow.
So if we look at kind of the diffusion of innovation, right, the beautiful chart, and we see, the innovators are the top 2%, well, healthcare is really where the laggards are.
Yeah.
They're really far, far behind. So in the last 2 years, we've seen e-commerce take off much more prominently than we ever have before. In the last 5, we saw direct contracts take off like never before. 10 years ago, when I was really in the heat of the direct contracting business, you had consultants for health plans that had never heard of this, and you have doctors that go, why would I sign up for this? I don't know what this is. Will I get in trouble with Blue Cross or United or Cigna? And so I think the answer really is innovation and where we're at. And I think with the shooting of the CEO from United, I think with all of the coverage that health insurance is getting, I mean, we're having conversations that we've never had. I've dreamed of having these conversations. Bloomberg called me in the last couple of weeks, Modern Healthcare, the Wall Street Journal, all these people that I hear from maybe once every year or two, all of them have called our office to say, let's finally fix it.
So your concept, or the concept that you're talking about, is I would have on my Amazon site or on my Walmart site or on a new site,
Yeah.
the ability to, the doctor prescribes this treatment or this procedure.
Yeah.
I would say, thanks, doc. And then I would, instead of waiting for him or her to refer me, I would go onto the website, find the location or put in my location and find somewhere on that website where that procedure is going to take place and select that.
So I would say all low acuity items, so I probably wouldn't include any big procedures, right, or surgeries.
Yeah.
Remember, it's, like for me, it's all thinking like Clayton Christensen. Start at the bottom and just kind of work your way up. And so I think the doctor says to you, Larry, you need physical therapy. Right, there's only 300 million physical therapy visits a year. Sorry, 400. Right, so this is a big market.
Yeah.
So the average hospital, health system, is getting about $330 paid when they submit, and the independents are getting $95. I mean, the arbitrage opportunity is so massive.
But here's the thing.
Yeah.
My doctor works for a large health system.
Yeah, that's a problem.
So they can't prescribe. They can't send me to ye local competitive,
Well, you see, now you've just hit on something that you probably didn't know you hit on. So there's a rule called anti-kickback and start.
I have anyway, yeah.
Yeah. And it basically says you can't pay someone or give them a remuneration for referring. But health systems have an exemption to the rule. So if I belong to a large health system, we're here in North Carolina, I'm going to pick on Atrium for a minute. I'm a primary care at Atrium and I refer a case to you in orthopedics. I don't directly get paid for that, but it is a part of, referrals are a part of my overall compensation.
Yeah.
Now, if we were in private practice and we did that, and you said, Dutch just sent me a $30,000 case, I'm going to send him a nice $1,000 bottle of whatever, we would both likely be prosecuted for large crimes. So in that example, that's a little tough, but here's where I liked your example. And the states of Tennessee and Texas are getting the marketplace ready for this. And I'm going to show you how. And I love Texas and Tennessee, work with both houses. They're really fantastic. They're very innovative for people not thinking they're very innovative states. They've said any and all cash payments you make count towards your deductible. So here in North Carolina, where I live in Arizona, that's not the case. If I go to a cash pay treatment and I pay $95 for a PT visit, my company doesn't have to count that towards my deductible. But in the states of Texas and Tennessee, they do. And so take your example about your doctor says to you, you need 8 PT visits, Larry. Well, now you go to Amazon and you say, oh, well, there's 4 in my local area. I really like this one. For whatever particular reason, you might like that one. Maybe they have good outcomes because most of them will show their outcome data. You say, I want that one, and that one is $100 a visit. Well, now you've paid for 4, and that counts towards your deductible in Tennessee and Texas. Here, it unfortunately doesn't. Remember, all insurance is state-run, so it's a little tough. But I think that's a really nice solution to have things count towards your deductible, because today people are not incentivized to shop because they have high deductibles, but there's no place for them to go and do it.
You know, in a way, this conversation is more enlightening than even the explanations you're giving me before, for this reason. Because we've gone through several scenarios and we've kind of skirted around the issue, if you like, because what we're saying is that there are so many different scenarios and so many different rules and so many different ways of going about this, or there could be so many different ways, but the average consumer, whether or not we work for a firm or we're on, as I am, I'm retired and so I'm on, some form of Medicare, it just seems to be far too complex and far too localized. So my doctor is part of the Duke health system, or actually they've just switched from one health Duke to some other provider. And by the way, there's complexity right there, because now I've got to move my medical records from this guy to this guy, and neither side is giving you the whole story of how to do it, and it's a mess.
That's a mess.
It's truly a mess.
And it doesn't even need to be.
Yeah, but it is.
But it is, yeah.
That's the point.
Yeah.
That's the point. So you're telling me these things as an expert, and I'm thinking to myself, how in the world do I navigate this incredibly complex environment, and why does it need to be so complex?
Well, it doesn't need to be, but it is because of regulatory capture. Remember, we talked about our good friend Bill Gurley.
Exactly.
And I only say good friend because I like him so much, but I've never met him in person.
Right.
You've had that privilege.
I met him in person, but I was completely idol struck. but here's the thing.
Yeah.
I mean, so we have regulatory capture.
Yeah.
Massive regulatory capture, which we should explain to people who don't understand what regulatory capture is that the regulators have become part of the firm that they're regulating, in the sense that that's how they earn their living, that's how they earn them. The regulators earn their money, and so the regulators do what the regulated folks want them to do.
That's right.
And so we're at the stage now where the guy in the middle, i.e. the consumer, we're caught in, we're caught by this web of impossibly complex situation where both the regulator and the regulated are playing this game with each other, and we're paying the piper.
Oh, for sure. Yeah.
So the solution that you've given me, or that I'm understanding you giving me, is throw this open for the vast bulk of the major work that's done. 80%, I think you said, 14 out of 18 billion processes. Throw this open to the open market and let people shop for the open market. But what I see in that solution is it's going to be incredibly difficult to force your provider, whether it's the local doctor or the local hospital, to allow you to do that.
Yeah.
Because they have control over the process.
Yes.
So if you're like on Medicare, as I am, I've got a lot more freedom to choose who I go to. But once I go to those guys, I'm on their web. They've spun their web around me. I'm done.
Yes. So you and I are talking about a couple of different things.
Yeah.
We've moved from the macro into the micro.
Yeah.
The macro solution, if we can talk about that for a few minutes, is price discovery, right? And here's what I mean. You have governments, single payer and universal payer governments around the world.
Yeah.
You have do it yourself, right? Which is Central America, half of Central and South America, parts of Africa and the Middle East, and certainly parts of Asia, where it's like sort your own life out, figure it out, and if you die, you die. Sorry.
Right.
And then you have Europe and the United States, and you have these kind of Western ideas. Well, I think when you and I first met at the All-In Summit, we had these long discussions because I had a whole healthcare kind of pod deal. And the idea that we don't have a commodities exchange for medical treatments and services is absurd. You've given too much power to the NHS and to Medicare, because we're going to pick on Medicare because
a lot.
And what it is they've not used any market pricing. They've dictated their own pricing.
Which has been horrendous.
Horrendous. Because more doctors are leaving Medicare than ever before in the history of our country. They're leaving and saying, I'm not dealing with it.
Yeah,
I'm getting out.
I don't blame them. Yeah.
Well, 19 straight years of less money while the health systems are making more for Medicare. Okay, so let's just talk about this overarching deal. If the entire world, right, and I'm talking about Medicare, the United States government, the Dutch government, right, Koninklijke, the NHS, the National Health Service, and all of these governments, along with the largest self-funded companies in the country, which would be, you talked about Warren Buffett, we talked about Jeff Bezos, we talked about JP Morgan.
JP Morgan,
yeah. So You've got all of these institutions.
Walmart. Yeah.
You've got all these institutions that are what we call self-funded, meaning they're entirely responsible for paying on the behalf of their employees.
Yeah.
They do not take out any risk. They use their own cash. Well, if those individuals had access to a global market, which we have for currency, orange juice, cows and cattle and pigs, and every possible thing in the world, including coins, right? Like, I always make fun of the Doge coins, but like, we have it for everything. But
by the way, and currency.
We have it for everything. We have 337 commodities markets around the world, but we don't have it for the one thing that, in my world, I would say matters. Why don't we have that? Why don't we say, we talked before about total joints in New York. 2,400 times a calendar day in the United States. That's a big number. Okay? They're $82,000 in New York City. Okay, they're no better in New York City. I love those surgeons. They're no better there than they are in Dallas, than they are in Houston, than they are in wherever. They're not any better. So if we had a commodities exchange and somebody from Zurich and from Nepal and from somewhere in Kenya had access to that price, you would have global concentration and you would have mean reversion. People couldn't get away with these crazy prices. That's the problem that I really want to solve, is how do we give the world access to better care at lower prices, and how do we use market drivers to do that?
So your idea is not to dismantle Medicare, and not necessarily dismantle Department of Health and Human Services, but instead to provide the providers with an open market to sell their services, and instead of Medicare prescribing what those services should cost, then by what are those codes? CPT code.
Yeah.
By CPT code, there would be bidding for those networks on a geographic basis.
Here's a for instance. We have self-funded employers today that say to me, Dutch, here are the 10 most utilized procedures that we use around the country. We're a multinational corporation. We have offices in 25 major cities. We need, these are our highest expenses: oncology, MSK, orthopedic spine. And we want you to fix that problem for us. Well, here's what I do. We go to the health systems, surgical hospitals, and physician-owned hospitals, and we say, I will buy all your utilization for the next 5 years. And here's the price I'm willing to pay. And I've never had a doctor or group of doctors look at me and go, you know what, we're not going to sell you our utilization for the next 5 years. They're excited beyond belief that they now have a contract with a AAA rated buyer that says, here's money, I'm going to give you. Because now what's the benefit? The benefit for these large multinationals is you have now hedged your expenses, the ones that are out of control. And what have you done for the physicians and the facilities? You've helped them with their long-term financial planning. You've said, look, you have 10 ORs, 12 ORs, 18 ORs. You know you could sell, if you wanted to build a few more, just sell a few more procedures. This helps everyone. If I think, because I'm from the Netherlands, if I think I was running the Dutch National Service, I want to find the best places around the world that did the most complicated procedures, that have the highest cost, and then where else could I go? Well, a commodities market does that for you, right? It does it for the really expensive stuff. I mean, lab tests, that's very local, right? That's where the Amazons come in. Hey, I got 15 billion are utilized in the United States, 6 billion in Europe. You put the e-commerce market and then you layer over it the industrial commodities market. Now you've got a real answer.
But these answers that you've given sound very familiar to me as somebody who participates in many of the many non-healthcare markets, but many markets. And I don't see any legal limits or the legal impediments to doing it. Why isn't it done?
That I don't know. So I came up with this idea for a commodities market in 2010. I did the hard work. I went to Chicago, spent a bunch of time in New York because I live there. We talked about that. And I couldn't get it done. But I recently started again.
You couldn't get it done because people wouldn't participate, or you couldn't sell the idea to the buyer? I mean, is it a buyer problem or a seller problem?
It was both problem because you're in the middle.
Okay.
You're an exchange.
Yeah, and but where did you find the resistance?
I found the resistance on the exchange level. So when I went to the CBOE and I started talking to the market makers about making a market in this, I got too much regulation, too much compliance. And what people will say is they revert back to their own experience. They go, well, I have an insurance company.
Yeah.
And the insurance pays, what is this? And so it took between 2010 and today, which feels like a millisecond, for people to begin like having the same experience I had, which was, oh, you know what? This really, we needed this. It's like the first time I got in my Tesla. I went, okay, I didn't know I didn't want to hit drive. I mean, now I just push the button up or I push it down. I didn't know I wanted all these user experience, like iPhone, same thing, right? You and I have talked about this. There's all these innovations. You go, it's the same thing with the commodities market. When I talk to these docs and I go, I know you're having a really hard time competing against the health systems. I'm going to help you sell all your inventory for the next 5 years. They're faced like, once they have the magic realization, like that's what's about to happen, they go insane. They're like, what? Oh my God, you saved us.
Would docs stop working for these health systems?
100%.
So you think that docs have all been eaten up or taken in by these health systems simply because they couldn't sell their wares, or what is the reason for that concentration?
This is a really good question. It goes to partly regulatory capture, partly government interference. On the regulatory capture side, you have what we call site neutral payments. So health systems, you talked about Duke. Duke is paid more, not because they ask for it, because they are assigned more by Medicare. Medicare doesn't negotiate. They assign reimbursements as a matter of course, like a matter of fact. If I'm an independent doctor and I call Medicare to get credentialed and to work through the process, I get assigned a reimbursement number that is a third or maybe 20% of what a health system receives for their employee doing the same work. And that is
why
CMS fundamentally says, this is what their outward view is, we must support hospitals at all costs. But the real truth,
it's a hell of a cost.
The real truth is health systems are supported by a $700 million public lobby that we know about. And
so this is the true regulatory capture problem.
Yes.
So the central issue about these health systems is that they have captured the CMS.
Oh, 100%. Yeah. And independent doctors aren't big enough. Like they can't raise $700 million. Well,
how do we overcome? How can you overcome that? If you set up a market, does the market distinguish between whether it's selling to a health system or it's selling to a private individual?
No.
So the health system is going to get reimbursed. If I go to Duke with a problem and they say you need a Duke doctor with a problem, and they say you need a
surgery.
You need a new hip. I do need a new hip. You need a new hip. I can go onto the open exchange and look for a new hip without having to refer back to Duke, or does Duke referral, how does that work? Am I free to do that?
I think it'd be more complicated as an individual buyer, to participate in a commodities exchange. But just as a matter is an independent physician, right? That's here that practices orthopedics will do the hip for significantly less with a higher chance of a better outcome, because they'll do 500-600 hips in a year, whereas the average orthopedist in a health system maybe does 5 a month, right? And so that's kind of that's where I begin to see the difference.
So your prescription for a solution seems to break down by the very existence of these health systems, because it's very difficult for me to move out of the health system.
Yeah.
I mean, my doctor actually works for a health system.
Yeah.
Being my doctor and 4 generations of our family, he's been the doctor, and he's an outstanding doctor.
Yeah.
But he's in the Duke Health. Well, they're now moving, but they're in the health system. So if he says, "Well, I'll refer you," do I ask him for a referral outside the health system so that I can?
Well, you're covered by Medicare.
Yeah.
So this isn't really a problem that I'm trying to solve. The Larry Goldberg problem.
But surely the Medicare, the expenses that Medicare incurs in all these procedures is a very large component of that $1.8 billion I'm trying to solve for.
Yeah, here's the thing. Here's what you really kind of frame this, and we talk about this a lot. Medicare is not in the business of trying to reduce its budget or its spend.
I get that.
Yeah.
But we have to reduce it.
Oh, we do.
Yeah.
And the way that they're going to do that is by stopping doing what they're doing and engaging in an open commodities market. And if they would buy from there and only reimburse, let's say Duke had to sell or decided to sell all of their stuff on the open market, then Medicare could also be a buyer on the open market.
Okay, but now we're getting to the central problem.
Yeah.
Because you're trying to solve for a problem for Walmart.
Yeah.
I'm trying to solve for a problem for the United States.
Me too.
And for the United States, while Walmart's saving, 60% on their reimbursements, on their total claims that they have to fund every year, is great. I'm really focused on that $1.8 trillion that just keeps going up every year and actually accounts for 80% of our future deficits.
Yes.
My focus is, we have to solve for Walmart's problem, but I'm much more interested in that $1.8 trillion, of which Walmart is a component, I agree.
I think the way I think about them is collectively. Like when I solve the problem of buying, because we are now having a reversion to the mean, and now we have transparent prices, now Medicare can't pay someone more for the same thing.
You think CMS would be limited to paying these hospital systems this gigantic amount of money?
I think they would be limited to paying what the market would bear. And so they would be forced to go to the exchange to do their purchasing.
Because right now CMS is setting the price.
That's right.
And you're saying the market will set a benchmark and CMS will be too embarrassed to actually charge more than that?
Yes.
I don't think CMS would give a shit.
Yeah.
I think they would just continue paying this high price.
They could, but everybody from around the world would participate. Because you have to remember, there's going to be, you and I do not have any quality information today.
Yeah.
We have none. You do not know the doctor that you're getting sent to. You just believe that they're going to do good.
Yeah.
In a commodities exchange, you have an immense amount of buy-side information and an immense amount of sell-side information.
Yeah, now that is true. Now the truth of the matter is, we used to, here in North Carolina, we used to revere the Duke Health System as one of the best in the world.
Yeah.
Well, the truth is they're pretty much journeymen. There's nothing great about Duke. That's what we've discovered.
No, and the thing that I don't love about North Carolina, now we're trying to solve the problem here, is that you have a certificate of need problem.
Yeah, so explain the certificate of need problem and explain that, because apart from this problem of CMS setting pricing, which is, I think, the root cause of the problem, and you talk about price discovery as forcing CMS to actually pay not negotiated prices, but to force the market prices. There is this question of constraint of trade or restraint of trade. So explain to us the certificate.
I would agree with both ways you've characterized it. The reason that Medicare can pay those higher prices is because there's a lack of supply.
Yeah.
Because if you're an entrepreneur, let's say me, and I want to build a new hospital here in Raleigh, I will have to go to the governor of North Carolina and ask permission, and I'll have to meet with what they call the Certificate of Need Committee here in North Carolina.
Right.
And so Certificate of Need exists in 33 states, mostly east of the Mississippi and Washington, D.C. But North Carolina is particularly egregious in this fact, that no requests to build new hospitals, including during COVID, were granted. And the reason that is because the people who sit on the committee are Blue Cross Blue Shield of North Carolina, which owns about 85% of all the market share, and then the largest health systems. And so Certificate of Need says if you're a doctor or an entrepreneur and you want to build a new medical facility in North Carolina, be it a nursing home, a small surgery center, a radiology center, a long-term acute care center, anything, you have to ask the governor, and then you have to go before the Certificate of Need Committee. And they generally don't want more competition. So states limit supply. Now in the 60s, they came up with this rule. It was a federal rule that became a not federal rule in 1968. And the reason they did it initially is because there was a limited supply of physicians. And they said, we can't just let physicians go wherever they might want. God forbid the market has anything to decide here. But we have to put them in places, and so that we don't want to overbuild anywhere, because then doctors would go to the overbuilding and then maybe patients wouldn't get the nice integrated care that they deserve. So what you've seen here in North Carolina is the rise of 3 health systems who've bought everyone because they get paid 2 times more, 5 times more, 10 times more, it depends on the procedure, than an independent practice. So here in North Carolina, you have a problem. Duke is artificially paid more for the work they do. And your premiums are higher because of it. And then when they send you to a doctor that's in the Duke health system, the primary care doctor is compensated for that. And now they'll tell you, I didn't do it to get compensated for it. And it's true. But guess what? If they send it outside, a guy that looks like me with an MBA will come to their door and go, hey, Dr. Goldberg, I saw that you sent a hip to your buddy from your country club. Did he pay you? No, this is exactly what will happen. I've heard this 10,000 times. The answer is no. Of course they didn't pay me. But I thought with this particular patient, he would do a better job. You know, here at the Duke Health System, fill in the health system name, I'm not picking on Duke, we don't encourage that kind of behavior. Would you like to continue working here? I mean, that's the conversation. And so you have regulatory capture with Certificate of Need that also is abutted with this wonderful provision in the ACA called 6001. And it's the moratorium on physician
ACA means?
The ACA, the Affordable Care Act in 2010.
Obamacare.
Yeah, Obama.
Let's call it what it is.
That's what people call it.
Yeah.
I try to be neutral, right?
I understand. All right, I'm just kidding.
Yeah.
You can call it ACA. Now
that you've said your piece?
Yeah.
So again, you have a constraint or restraint of trade. Because you have doctors who built 300, 400, 500 hospitals. And then one day they're told, guess what?
No more.
You can't build any more new ones. And the ones you have, you can't expand. Oh, you have 4 ORs? That's it for you. Imagine telling an entrepreneur, I'm sorry, you have this really nice restaurant. I know there's lots of people that go to it, but you can't build a second location, or a third one, or a fourth one.
It sounds like that conversation where the guy says to you, this is a really nice restaurant you've got here.
Yeah, right? And so when we talk about healthcare in the United States, this is what 99% of people don't understand. It's a mix of lawmakers,
Yeah.
right? And really they're lobbyists and the people that work in the lawmaker's office, right? The bureaucrats, if you will. Some good, but mostly not, right? They live in the world where they help the corporation that they eventually want to go to work for.
Now, so let's get very practical here. We now understand the problem, and you say the problem is largely regulatory capture and price discovery. The lack of price discovery is a sort of outgrowth of regulatory capture, or regulatory capture is the outgrowth of not having price discovery, or I'm not even sure which came first and whether one's a chicken and the other's an egg. But we've got two major problems. Can price discovery solve for regulatory capture? You said that if we have price discovery, then Duke will be too embarrassed to charge 20 times or 15 times or whatever the times of the price. On the other hand, the patient doesn't get to see the bill, so what does it matter what they charge? I'm back to the question, is do you really believe price discovery will solve this huge problem that we have of this closed shop that the ACA, that Obamacare, I wouldn't say Obamacare created it, because I think it had happened long before Obamacare. Obamacare just helped institutionalize it and seal the deal, as it were.
Yeah.
Do you really think price discovery is a powerful enough force to actually break that paradigm completely, or would we need some sort of deregulation process to solve it?
If I had to choose, I would pick price discovery over deregulation.
Yeah.
But I think I'm going to get my way in the next couple of years, so I choose both.
Yeah. And when you say you think you're going to get your way, have you spoken to Vivek Ramaswamy? To Vivek?
No, but I've spent the last 4 years.
Yeah.
Literally the last 4 years. I'm in DC every month.
Yeah.
And I'm meeting with the bureaucrats, the lobbyists, the middlemen, the lawmakers.
But you haven't met with Doge themselves.
No, because that's all new, right? That's all in the last, call it 6 months.
Right.
And I'm not in that circle, but I'm certainly in the circle of lobbyists for the healthcare, for all the insurance carriers, lobbyists for the health systems, lobbyists for anything that really has to do with healthcare.
But they are part of the capture system. It's
Yes,
not going to be in their interests to break that system.
That's right. But I am working with them, and I am working with the lawmakers that they support.
Yeah.
And these are things that, like, until I went there, until I started spending time in I didn't understand. It's a really, you talk about a swamp or a captured system, it really is. Like, how do you get good regulations? How do you get good ideas turned into policy, turned into potential laws? Why does every regulation that says we're for patients really include 80% that's really anti-patient?
Right.
Like, how do you get rid of all of that? And I think this new Doge process, I'm hoping it works. I'm all in on it. So let's take it rule by rule. First question, why do we pay people differently for the same things? See, CMS is highly supported by by commercial insurance. Remember, commercial insurance wants higher prices, higher premiums, right? There's lots of people in the world that go, Dutch, the insurance companies really offer the lowest prices. And I go, well, what incentive would they have to do that? What I don't like is I don't care that they're making a lot of money. I could care less. What I don't like is that they've removed competition.
Right.
And I think in a capitalistic free market system where you and I live, at least ostensibly, I want competition. And until, we all know perfect competition eliminates margin. And that's what I want to see. And so I'm going to be for any system that helps us do that. I want prices to get as close to zero as I can get them. I want higher quality outcomes, and I want lower prices. And the only thing I know that does that is price discovery, which creates competition.
So that is a first principle.
Yes.
And to get from first principle to implementation, you have to go through a very significant amount of work. Now, your theory that if we just create this market, they will come. The reason that I think that will struggle to emerge as a solution is because the regulators are incredibly ingenious in creating structures that make this impossible.
Yeah.
So, short of making price discovery illegal, which, I wouldn't put it past them. I mean, if we were living, under a different administration than the one that's coming, I would certainly think, and if other people were in Congress, I would certainly think that they would be able to pass a law making price discovery in the medical
100%.
processes illegal. But since they can't, it does seem to me that only a Doge-like process could break the spell. And it seems to me that this is such a critical message because, Doge could certainly remove $500 billion from our budget.
We're going to spend close to $5 trillion this year.
Oh,
and I'm at maybe 2.
Yeah,
and I'm not being facetious.
No, I'm 100%. I don't think people realize
they have no idea.
that the real budget crisis is not the military. Certainly not the military. It is not, the bloated bureaucracies of the various departments. It is not even all the pressure that these new regulations that these regulatory bodies create that are really laws. It's not all of that. If they just look at medical costs in this country,
we'd solve the problem.
We'd absolutely solve the problem. And so if Doge only focused on healthcare, that would be a key to unlocking.
So let me just say this because I'm very pro-America, right? One of the dreams of doing this work is so let's just say I'm 85 today, right?
Which I'm practically, by the way.
You're pretty far away. If I'm 85, here's what I want. I want this marketplace built. I'm going to build it. Like, it might take me another 5 years, but I'm going to build it. What I want is I want the world to see how good healthcare actually is in the United States.
Yeah.
Now, people say all the time it's all going downhill.
Yeah.
And as a macro, it is. But there are certain specialties and subspecialties at which there is no one even close to as good as we are.
Right.
So we did a white paper in 2011. I told you I was in London. And we looked at NHS prices that they were paying for their own goods and services on an accreted cost of goods sold model.
Right.
Okay? So a total joint, right, because they don't have profit margin built in, that has a cost of X, right? So it's just the cost of goods sold, whatever makes up. And I compared that against private practices in the United States. Guess what?
They're much higher?
We were cheaper here.
Yeah, they're much higher, yeah.
And so...
And it's true, I bet you go anywhere on the continent, you'd find the same problem.
Right, and so what I've been trying to say to many administrations long before this one is, hey, and I use very colorful language because I can get kind of passionate about it, is, do you know how many surgeries they do over there? Do you know how easy it would be to do a government deal with them to say to the NHS, hey,
we'll do it all.
We'll do it all.
Yeah.
Give us X dollars. We will fly people, we will pick them up in our airplanes because we build airplanes, you do not. We also build hotels. You don't build great ones. You used to, but you don't build great ones anymore. We'll pick them all up every Monday and we'll bring them back on Friday. And we'll save you half.
Yeah. We'll suddenly turn NHS into a profit.
But that's the power of price discovery. Sorry, I get
No,
I just go, this is very common sense, but it's also common sense for Dutch people. Yeah. We are highly pragmatic. We believe 1 + 1 is 2.
So That's two for the audience.
Yeah.
But in all seriousness, Dutch,
Yeah.
I mean, it sounds to me like you could definitely solve for the pricing problem, and it seems to be that, you know, that would be a huge that would have a huge impact, and it sounds like a really good solution. And I would highly recommend that you take it to Vivek and Elon, because it just makes sense, and these guys are first principle thinkers. Let's now leave the question of cost of healthcare as a solved problem. We've solved it, and we give it to the world. We give it to the world.
Yeah.
Let's move on to the other side of the coin.
Can I make one more?
Please,
Just what, because this is important. You and I started this conversation off about debt.
Yeah.
Right? We're 33 trillion deep. I posted this morning. It's going to be 51 on the current, 51 trillion if we keep going.
Yeah.
On the same trajectory.
Yeah.
The global marketplace, so the TAM, if you will, total addressable market, on procedures and surgeries, not on little stuff, like below $6,000 as you discussed, is somewhere nearing $15 trillion.
1.5.
Yeah, that's big.
That's huge.
Imagine we capture, right? Because we have big enough leaders. You mentioned Elon. You think about Peter Thiel, David Sachs, Chamath. You think about these great, like, these good thinkers that they can build products and deploy them, right? A really hard skill, as you and I know. Or guys in financial services that they know how to, like, they innately know how to do these things. Imagine attracting just a bit of $15 trillion. You talk about solving our deficit problem. I mean, we're not going to capture 100% of it, but let's say you capture 10. And then you capture 20, and then 30, and then the world starts understanding, and I'm 85, and I go, what did I build for the world? You're welcome. All I want's $1 a year.
Well, I think we can afford $1 a year.
Yeah.
Now, look, your point is extremely well made, but you know, we have to take that message, and we have to, you know, transmit it to not the powers that be, because the powers that be are captured. We have to break the mold, and you know, Doge is created to break the mold. So I think that, and those guys they're builders. They're
builders.
Yeah,
they're real builders.
They understand. Yeah. Let's turn to the other problem, which is the mirror image. It's not the mirror image, it's the other side of the mirror. Actually, it's the crazy mirror. Let's talk about healthcare, and let's talk about the health of the American citizen.
Yeah.
Which seems to be going very rapidly into the toilet. I mean, almost literally. I mean, it's a very serious problem. Is RFK Jr. You know, people think he's got some crazy ideas, and I think he does have some crazy ideas, but he's also got some very good ideas, and they live in one person, I think. But what is the solution to health in general in the United States? Why is it that our you know, life expectancy is going down so dramatically? Is it all weight? Is it all overweight? Is that the problem? Is it our healthcare system? What is the problem?
You know, I'm an accountant, not a physician.
Yes.
Right. Okay, but I do have some thoughts. This is really important.
See, I don't think the physicians have solved the problem. I think the physicians have caused the problem.
No, and I don't think they've caused it. But they, right, but this is why I like you, right? Because we can just have these conversations.
Yeah.
This is what people will never appreciate about Afrikaners and Dutch people, is that we can just argue and it's fine.
Yes.
Americans as a whole, they have a harder time with it.
They have to.
I don't not like you because you argue with me.
Right.
I might like you more, in fact, because I want to hear the other side. Maybe I didn't think of it. Anyways, look, I'm very pleased with JFK, Marty McCary. What a find.
Yeah.
Absolutely amazing. I wanted someone else, but they chose Dr. Oz. I like to remind people, because people are quick to make jokes, right? In the intellectual circles, if you will. The guy is a cardiovascular surgeon, cardiothoracic surgeon, excuse me, and got his MBA while he was going to med school.
Yeah.
I'm sorry. Like, wait, you went to Penn and you did both at the same time? Well, you're a real idiot. Okay, the guy's up here.
Yeah.
He reads. Now, do I disagree with some of his views? For sure. But to argue that he's not brilliant, that's not an argument to make.
Yeah.
In fact, it's you should just leave it over there because it doesn't matter.
People who make that argument are exposing themselves for... Anyway, go.
So I like RFK. I think he's got a really good handle. So he's got a couple of competitive thoughts, right? Some people are really... You are either believe in vaccines or you don't. Right? There's that.
My understanding of RFK Jr. is that he does believe in vaccines, but he's very skeptical that some vaccines have caused some serious problems.
See, in the physician world that I live in, most don't want to hear that. They're like, it's black and white, and I tell them, I go, it's not black and white.
Yeah,
it's not black and white at all. So I want people to ask those questions, and I'm very much in support of Robert Kennedy doing that as a health initiative. There are the second group is the GLP-1 or no GLP-1 drug group, right? The Wegovy's, Ozempic.
Yeah.
I love reading about them. My wife is a neuroscientist, studied at King's. I love her views because she reads the studies and has helped me over the last 7 or 8 years understand the language of studies. They're really hard to read if you're just a normal person.
Yeah, no, I've delved into that.
But she breaks them down for me, and then like she's taught me, right? That's what a graduate degree at King's will get you. So, and the third piece is food, made popular by people like Callie Means, who used to be a food lobbyist. He was on the other side. So you've got these kind of 3 initiatives, and I'm of the viewpoint, not being a clinician, where I go, these are the 3 we ought to look at. We ought to look at food because we're being fed. When I look at what we're fed in the Netherlands versus fed here, what's illegal in the Netherlands and my brain asks the question like, well, why? You know? And so I think you're starting to see a large outpouring of curiosity around food. Is 20 Diet Cokes a day good for you? Well, I mean, but this is literally what people do.
I know.
And then they say,
I think Elon does that.
Does he?
Yeah.
And then they say, well, I don't think I've been to a fast food restaurant in it might be 15 or 20 years.
Yeah.
But I have friends that literally they come to the office to see me or something, and they have a Brahms bag or a Whataburger bag or a taco bag, and I go, like, are you insane? That you're going to eat cancer? You know, this is bad for you.
Yeah.
So I think I like the conversation we're beginning to have about food. The GLP-1 drug, is it good? Is it bad? That's a really good conversation to have.
Yeah.
You know, so I think health as a whole is moving in the right direction. I think doctors...
You mean the discussion about health is moving in the right direction? But I don't think the numbers are yet moving in the right direction.
No, but I think they will in the next 5 to 7 years.
You think so?
Oh, I'm 100% confident.
See, I'm in the opposite camp. I don't think all the discussions in the world are going to help. I think it's a function of what happens when a human being becomes extremely comfortable and secure. They tend to lose the need to survive and to do what it takes to be healthy or to... I think we're just too wealthy. I think we've become too wealthy and too comfortable. That's one side of it. And the other side of it, well, maybe, it's too complicated.
It is a complicated issue.
I don't think there's a simple solution because I've seen in Europe people are becoming obese.
Oh, isn't that interesting?
Yeah.
Like my last few trips, I'm like,
that's strange. Yeah.
Yeah, this is interesting. Like I'm not used to seeing this.
Right. So even in the Scandinavian countries, I've seen people. Definitely, people are becoming heavier. And so, maybe it's just the scourge of wealth. It's possible that it's just the scourge of wealth.
It certainly could be. I think the trend for people going out to eat, I think we've seen the peak in that.
You think so?
Well, I mean, I used to go out to eat before I got married and had kids. I think I went out to eat every day. Like I barely ever. Why would I cook it? Like, why would you cook at home? Like you're at the office, you're busy. You come home at 9 or 10 o'clock at night. Like you're not at home.
But the modern generation are not cooking at all.
I think the exact opposite.
Really?
I'm seeing all these people that are in the same situation I'm at because I'm older. Yeah. But I see all these young married people with children, not without, not dinks, with children, and they're all reverting and saying, oh no, we're gonna eat at home, we're gonna be healthy. And the moms are really driving it because they're saying, I now have children, this is no longer an issue I didn't think anything about, now I actually think about it because I have offspring.
Yeah.
And so, like my wife has, they call themselves the, I forget the name, but they have a name for their little group, and it's like 8 women, and just kids. All the kids are the same age. They're all under 7 or 8,
right.
And they all eat super clean. They all work out, not in a crazy steroid barbell way, but like they all work out. They take care of themselves. They're fit, and I'm like, I've never seen this. It's more holistic. And I like what I'm seeing.
It's a very small sample.
It is.
I worry. And what's interesting to me is in those societies where we don't have overweight, particularly the Asian societies, the other side of that particular picture is that they've stopped having babies.
Yeah, there's no one left.
There's no one left.
Why do you think that is?
It's a very worrying trend, and I know it exercises Elon Musk's mind very significantly, but to me, the two are somewhat related. The issue of, being too wealthy to eat well, and then being too wealthy to have children. I think they're part of the same syndrome. And the syndrome is just, the wealth of societies. And it's just fascinating to me and very worrying, actually, because I will not see the other side of this, see whether there's, this is a peak and then it, comes down and people start having children again and start eating better. I don't know. It's a mystery to me. But I think it's part of our healthcare crisis, our healthcare cost crisis. Mm-hmm. And I think until we start, and you can't legislate it. You can't, there's no law you can make against it.
Now, there are European countries, especially on the Eastern Bloc side, that are saying, hey, you have more babies, we'll give you more money.
Yes.
Because they want to reverse the trend.
But it's unclear that that's going to make a big difference. It's
100% true.
Yeah.
I like the idea of it.
Yeah.
I don't know if there's hard evidence to support government intervention, in more babies.
Yeah.
I do. I like the idea of the conversations. I don't know if it will lead anywhere, but I'm happy in the direction we're going. Like,
I think we've identified the problem.
In the last, I'm not quite sure, but in the last 4 or 5 years, and I've said this to a lot of people, is I felt like I got told to shut up and be quiet and don't say anything. And I didn't appreciate that. So I got all the vaccines there ever were because I went in the Marine Corps. I don't know if there's a video, like we got to find this. You literally go, you're on an escalator and you start going up and there's literally people shooting you with injection guns. And the last time I heard somebody count it, it's 26 vaccinations and injections of some type. So that's the first week of boot camp. So I'm not anti-vax anything. But the idea that you can't ask questions, like that just wholesale bothers me.
I grew up in the polio period. I don't know if you know how terrible that was, but we had kids on our block become permanently crippled for life. We had one kid pass away. I was diagnosed with polio.
Yeah.
I had a disease called Perthes disease, which is your hip kind of disappears on you and then you lay it up in hospital for a couple of years. Today, they don't actually lay the kids up in hospital. I was in hospital for about 2.5 years with this Perthes disease. And they nearly sent me to the polio hospital. There were isolation hospitals where the polio kids were. They nearly sent me there because I was diagnosed with polio until my father, who's a physician, stepped in and said, wait, this is not polio. And then eventually I landed up in a children's hospital where I lay in bed for a couple of years. So I am, so aware of polio. It's incredible. Today, nobody thinks about polio, as a serious disease, but boy, you lived in fear, literally. You lived in fear and you were kind of kept by your parents in the house, not allowed to go out, not allowed to play. It was pretty serious. For a couple of years when I was, somewhere in the range of 6 years old. So
those are life-changing things. You can't undo it.
Absolutely.
It's like when my uncles, not my mother's brothers, but my Oma's brothers, told me about the war.
Yeah.
And like living through hey, we hid in the kelder, the cellar, and then we did that because the Germans just kept dropping bombs on us. And I think to myself, well, how do you, is there any normalcy in that, right? And the answer is you never outlive it.
I never do.
No.
Yeah.
But asking a question about a COVID mRNA vaccine is very different from asking a question about a polio.
No question about it.
And when I had kids, they told me, well, your children need these injections. And the first thing the pediatrician said is, I don't want to answer your questions. And I thought, well, that's just silly. I'm totally naive. I'm not claiming to be a doctor. I'm just a guy who's a parent. And when you become a parent, you're going to be a helicopter for the first few years. So I think the one interesting point about the doctors is I see doctors, the lens in which I see them, and I've worked with them for a long time, as you know, is not that they are responsible for your health. They are, however, responsible to make sure that if you're lying there and you're about to die, that they help you recover.
Yeah.
So the role of physicians, I think, as I see it moving forward, and that's kind of a nebulous phrase, but I see them more in the acute world. And I see the rise of some type of clinical study with a different type of study, and I don't know what that might be. And it's more of a health coach or a health empowerment. Yeah. But it's not an MD. An MD it's too scientific. You and I agree that there are scientists, and when you're a scientist, you use the scientific method, but that's not the only way to get to the conclusions. You can say, well, I have a historical perspective, or I have a religious perspective, or I have a philosophical perspective, right? All the fun things we learned in school. But when you're a scientist, you just use the scientific. And so I think maybe that's not the route to health, is just the scientific outlook.
And the other thing is the scientific health outlook has become politicized. So people saying, I represent the science, is one of the worst phrases I've heard from a political and from a human perspective that I've ever heard. I mean, it's pretty much like the Galileo story. It's pretty much the story of the scientist becoming, the ogre in the fairy tale. So we've solved the problem of the cost of healthcare and its price discovery, but we certainly haven't solved the problem of health in modern living and what ails our society. And I think that's a subject for perhaps further pursuit and further introspection. I mean, I think the health there's going to be a renewal in the science in this new era. I'm hoping there will be a renewal and that there won't be a reversion to some kind of, diktat from the science. Right. And I think that would be good for health. Any last minute thoughts about what we need to do to save ourselves, to save our society from this, what looks like a very serious future?
I don't think that policymakers will regularly ask me, what policy initiatives do you have to solve this problem? And I don't think it's a policy problem. I'm not here to have a religious conversion conversation.
Right.
But I do think we shifted at some time, I don't know what the pinpoint is, but we shifted from a moral and ethical society to one of legal and illegal. And I think health has a correlation, maybe not causation, but I think it has a moral perspective. Right. When you believe what I believe, that your body's a temple, now you wake up and you say, okay, I have to go for a walk. And when I look at what I take into my body, I say, oh, okay, well, Reese's peanut butter cups might taste really good.
But it may not be.
But is it an act of service to the creator? Right? I mean, that's genuinely what I think. And to myself, I go, no. Now, did I think that way when I was 30 or 35? No. I was doing shots and I was having a great time, and But as I got older, I began to consider those things, especially when I had children, right? Because that's when it all kind of comes back. Yeah. So I think when it comes to health, we're not quite looking at all the perspectives that are necessary to answer that question. I think we need a bit more introspection, and I think we need to be, and I think we're going to see it. I think we're going to see a large interest in introspection. And is illegal and legal really the right way for us to go? Or just because I can, does that mean I should? And I think that has to do with our health. Because I don't think you can be healthy by yourself if you have no accountability and you have no reason or purpose to live other than whatever it is you're trying to do.
Well, we'll leave it there, but I want to thank you very much indeed. I think I learned quite a lot today, actually. I honestly, to be, if I were to sum it up, is I hadn't thought of price discovery being at the bottom but if you go to first principles, I think that is a first principle. So this has been very illuminating. Thank you very much.
You're welcome. I'm so glad to have been here. Thank you.